Welcome to the second in the Antibiotic Stewardship series with Dr. Kelly Wark. My name is Nadine Hagmeyer, and I am your default moderator today because Loretta is out in Kansas teaching Project First Line. So bear with me as I navigate all of the Zoom things by myself. I don't usually manage all of it by myself, but we'll be successful. So today's is the Focused Antibiotic Stewardship Initiatives directed towards wounds, skin, and soft tissue infections. And before we get started, I do need to remind you that if you're seeking continuing nursing education, please stay on for the entirety of the presentation and complete the program evaluation form at the end. It should automatically pop up at the end of the webinar, and certificates of attendance and C&E will be sent out to you via email. We are recording today's presentation and encourage you to share it with your colleagues. However, please note that continuing education credits will not be available with the recording. If you have any questions about that, please reach out to Loretta Fitzgerald, who, as I said earlier, is on the road today. There will be some polling questions, I believe. Kelly and I were just talking about that. We're not sure what's in there, but there will be. Otherwise, if it doesn't pop up, we'll have you answer the questions in the chat. I would like to also say, please put your name and organization in the chat so that we can counter that to our attendance logs that we get electronically to make sure we have everybody captured. Hold on, I clicked to admit a bunch of people, so let me get back to my form. I would like to introduce our presenter, Dr. Kelly Wark. She's an assistant professor of infectious disease at the University of Kansas Medical Center, as well as the subject matter expert of antibiotic stewardship, healthcare-associated infections, and antimicrobial resistance in the Kansas Department of Health and Environment, HAI-AR section. And at KDHE, she is the antimicrobial stewardship co-lead, and at KU, she serves on the antibiotic stewardship program and is co-chair of the vaccine and ambulatory subcommittee task force groups. I also would like to say she is the queen of toolkits, and her ability to put together resources for you all is absolutely amazing. Welcome to Dr. Wark. And I will share my screen so that you guys can see her slides.
Thanks, Nadine. Yeah, I do a lot of toolkits. If anyone has any toolkit needs or ideas, feel free to put that in the chat too. I'm hitting an empty zone. I've actually caught up on all my toolkits, so I can start working on another one. Okay. So today we're going to talk about kind of focused initiatives for skin, soft tissue infections, and wounds, and improving antibiotics around those. Next slide, please. Next slide, please. So first, we're going to go over some of the epidemiology of wounds and skin and soft tissue infections, but the bulk of the discussion will be kind of identifying some stewardship initiatives to improve our antibiotic use directed towards those types of conditions. We're also going to talk about some effective communication strategies on how to improve the ability to optimize our antibiotic uses for these conditions. Next slide.
Maybe. There we go.
So just a little bit of background in the EPI. So from 2000 to 2010, this was a evaluation of antibiotic prescriptions for those over 65. So not just related to skin and wounds and stuff, but there actually was a significant increase in antibiotics for this population over age 65. And so the average person over 65 is getting prescribed more than one antibiotic course per year. But as we know, many people are getting are accounting for multiple courses, but the average was 1,048 antibiotic prescriptions per 1,000 persons. And so at any one time, about 10% of people in nursing home are actually on an antibiotic on any given day. And you can see here from the little graphic, and 70% of people in nursing homes are getting antibiotic, but around anywhere from 30 to 50% of those are not indicated. Next slide, please. So as for cellulitis, so this accounts for a good proportion of antibiotics that might be amenable to some optimization, accounts for a lot of hospitalization. So every year in the US, over 14 million people are hospitalized, or not directly attributable to cellulitis, but in the hospital they have cellulitis or skin infections or wounds. So this accounts for just a little over 500,000 hospital admissions directly. And actually within hospitalizations amounts for about 10% of all the infectious disease issues that require hospitalization. So a significant amount of antibiotics, as you can imagine, are going towards these. For nursing homes, it's actually the third most common infection diagnosed. You can see here from the graphic. I got a little heavy on the bio rendering graphics. So these are all ones that when I get kind of tired of my content, I go to my graphics. But you can see here that the number one is pneumonias, followed by UTIs, and that's closely followed by skin infections. However, because of the nature of the setting, the bulk of these, really over half of them, are prescribed antibiotics by offsite providers. So there's difficulty having assessments, and then follow up to make sure that these are improving. Really under half of those have documented follow-up. Next slide. Moving my microphone so it doesn't make that noise. Okay, so there's a lot of mimics, and so this isn't just in the long-term care population, but this is all comers for cellulitis. So it's a universal issue. They had like dermatologists compare these cellulitis that were getting diagnosed, and really cellulitis is the most frequently misdiagnosed conditions among dermatology evaluations. Anywhere from 30 to up to three quarters of these are that were initially diagnosed as cellulitis are actually given an alternative diagnosis on further evaluation. So a lot of mimics out there. Next slide. So, and really what we see for the mimics, if you're going to see what you see here on the right side, the bilateral. So given the nature of skin infections, or really any infection, pretty odd for bacteria to attack at two distant sites. So if you're seeing someone and they, they think that they have cellulitis and it's bilaterally, search for alternative diagnosis right there, because bilateral cellulitis is definitely not common. So generally with cellulitis, you're going to have it be unilateral. You can see like this photo where you'll have like these really demarcated lines often. It's of course going to be generally pretty sudden. You might have warmth, you might have some pain, versus the non-infection. So again, it's going to be both sides, but you can sometimes get these chronic changes like you can see in this picture. They might have other symptoms. They might have pain because they might have swelling or conditions that have led to that redness, but they frequently will have itching or burning. These two could be infection if they're having these symptoms. And then you might see some changes like flaky skin. It's going to get hyperpigmented. Both legs look hyperpigmented. You can have a lot of this kind of stuff that will kind of excoriate off of it. And you can also get, depending on how edematous is, a lot of macerated skin too. And all of these things will make them at risk of getting a skin infection. But if it's of this nature where it's kind of this bilateral, it's unlikely to be a cellulitis. Next slide. So here, so this is the kind of generally differential for right leg. So again, you think of unilateral, acute, sudden, well demarcated, like you can see up here in the right corner, versus some of these other conditions, like the ones on the kind of right below it. It's still unilateral, but also don't forget about things like DVTs, or even things like if they have a weird looking kind of redness, think about other things like vasculitis. Certainly for like gout too, people with like, especially the toes, think about conditions like gout that could mimic that. When you get into the more chronic appearing ones, so again, starting to look at like both sides, both legs, and kind of the pretibial aspect right above the ankles, But you can see here this picture of this stasis dermatitis. So this really dried, flaky, it's going to be itchy or sometimes can be burning, really uncomfortable. There's also conditions like this. You can see right below that lipodermatosclerosis, basically just this kind of starts to get, as the chronic swelling, you start to get this scarring in that subcutaneous tissue. And then you can have these chronic changes where they'll look kind of red, and then eventually they can evolve into getting like more of like a dark purplish or even like a brown over time. And then unilateral kind of chronic things also, we might see this on the hands, for example, or stuff like contact dermatitis, tinea too, where if it gets to be pretty bad, they can get redness around the toes also. And then there's a good resource too, where I kind of pulled a lot of these pictures are from the link right there, the pcds.org. Next slide. So another also mimic, so this incontinence-associated dermatitis, so form of contact dermatitis. And so that urine and feces are actually both chemical and physical irritants. So what they do is they drive up the skin pH. It increases that permeability of that skin. And so then it turns into increased risk of breakdown of that dermal layer. And then you combine that with shearing and friction forces, and then you get that skin kind of starting to slough off. And that's really when you can then, of course, get risk of infections also. If we're getting a lot of urine and feces in that area, of course, it can get, it can be a wet area. And then you can also, as it dries, then it can get into that kind of drying, flaky skin that can be itchy. But you can also get a risk not just bacterial infections, but when we're talking these wet environments, they can really be at risk of candidal infections also. Next slide. So these are surveillance definitions that you're all familiar with, so the McGear versus the Loeb minimum criteria. That really is meant as kind of a screen for cellulitis. And so you can see here kind of the criteria. So McGear criteria, if there's pus at the skin or soft tissue site, or 4 of the following that are listed there. Versus the Loeb, the minimum criteria, again, purulence at the skin and soft tissue or wound site with only 2 of the following. So you can see here, some of the 2 of the following are increased redness, increased swelling. So there's a lot of other conditions that can explain for that. So it has to be applied, particularly when you're worried about infection. So the Loeb in particular, they compared, it's meant to be more specific. So we want to identify the skin infections versus, the sensitivity where we capture everything. We really want to be specific, making sure that we're identifying our skin infections. And while the Loeb might be less kind of effective for UTIs or pneumonias, for skin and soft tissue infections, there was a recent article, I think it was Clinical Infectious Disease, and it really actually did have the best, both a good sensitivity and a high specificity, was over 90% for skin infections in particular. But keep in mind, these are also surveillance definitions. And so just identifying some organism that's cultured from a wound is not sufficient evidence that that wound is infected, because as we'll go over here in a bit, it's very common. It generally, universally, they'll have bacteria in wounds. Next slide. So I do like this one. This is from Spice. This is kind of some of the Loeb and McGear criteria, where actually I like the way that they kind of phrase some of this stuff. And then they also have kind of checklists also for scabies, fungal infection, herpes. So I like this one. I was looking quite a bit. If you guys have any that you find particularly helpful, feel free to pass them on to me or put them in the chat. Next slide. One thing also, so specifically for cellulitis, this is a newer model, and this is available on, if any of the providers use MD Calc for a lot of our calculators for looking, this is there, but it's the Alt 70. And so this was developed specifically looking for cellulitis. And you can see here, you can plug in kind of these 4 criteria. So is it asymmetric? Are they over 70? Do they have a white blood cell? And this was developed specifically for the ED setting, but really it could be used anywhere. and then heart rate over 90. And so then it will give you this score. And if the score is, you can see here 5 to 7, it's highly likely cellulitis, versus if you get into the 0 to 2 range, then you should be looking for alternative culprits. So this was, I think it was some academic institution on the East Coast that's really done a lot of work on this. And they validated it. And as I said, it's developed for ED, but it really, given the age group and kind of they've incorporated that into their algorithm, it's a good, I think, option to kind of help determine cellulitis probabilities. Next slide. So we're hitting on a poll question, and if the poll doesn't pop, you can feel free to put it in the chat. This is really just more for information. It's not right or wrong answer, but does your facility have a guideline for cellulitis? Not yes or no. There, it popped up.
Yeah, I had to do it, FYI. We have 62 out of 83 attendees who are answering the poll. So we'll give it, there's still a few coming in. $65, $66. Tell me when you want me to stop it, Kelly.
You can stop, yeah.
So it looks like we had 22 out of 67 say yes, 40 of 67 say no, and 5 are not sure. Oh.
So great. So actually, so that's pretty helpful. So actually I provided some kind of example guidelines on the next few slides if you want to advance, Nadine. Perfect. So these are based out of, and I cited the variety of the guidelines. So these all are basically, you should get the slides, but these are a good basis if you want to actually develop some guidelines. And also I kind of threw some pictures on here too. So with some of the pathogens, which I always think is very helpful for kind of thinking it through what kind of antibiotics we're going to use. So here's some examples of impetigo. So you get that crusty kind of stuff. Usually that's either going to be your Staph aureus or your Strep pyogenes. And these are the recommendations per as I mentioned, the Stevens and the clinical infectious disease for these ones. The duration is 5 days. If it's very superficial, you can get away with just the topical mupirocin versus systemic antibiotics for the if it's a little bit worse. And then you can see this picture of erysipelas. This one is much more frequently, you're going to pretty universally, it's going to be strep, whether that be group A strep or some beta strep. So that treatment you can see there, and then some penicillin alternatives. Next slide. And then this is really where a lot of, I feel like, our improvements can be had. So the non-purulent cellulitis, which really makes up the bulk of cellulitis that we're going to see. And this is mostly going to be strep bacteria. So less commonly, if you're not seeing pus on it, it's less commonly going to have Staph aureus. So really you can target with just the cephalexin or cefadroxil is the options there. And then you can see penicillin alternative under the one below here. If you get into purulent, that's where really the staph, either MSSA or MRSA comes in. And so subsequently you target that just covering with additional MRSA coverage with either the Bactrim or the doxycycline. And 5 days for pretty much all these, although you can extend if it's not resolved at the end of that. Next slide. And then similarly, this is if you have, just building on those guidelines, if you have a drainable abscess and it pretty much you don't have any adjacent redness, you can get away with just doing that with that IND. So the criteria technically says, you know, if they're under 2 centimeters, not a lot of redness, then really just drainage alone should be sufficient. But you can add extra antibiotics such as the Bactrim or doxycycline if it wasn't drainable. So that is something I feel like you guys could easily adapt, and depends on kind of your population. You can use those to help build on your facility guidelines. Next slide. So moving on to the epi pressure ulcers. So you can see here how the rates increase with age, and it tends to be up to about age 50-ish. 56, 50 to 60s, a little bit more common for male. And then as the age progresses over 60 to 70, really female starts to become more frequent with pressure ulcers. But this accounts for a huge amount of incident infections per year, actually 130 per 100,000, 2.5 million pressure ulcers per year. So we have a lot of these in the US. And actually, when they compare people that have the same risk factors or the same comorbidities, so they're diabetes with coronary artery disease, someone that has a pressure ulcer versus someone that has those same diseases but no pressure ulcer, that person that has the pressure ulcer has a 4.5 fold increased mortality than that person that doesn't have that pressure ulcer. So it's kind of a marker also of some worse clinical outcomes that they could have. Next slide. They're also very costly. So this was some older data. I tried looking for some newer kind of costs, but per ulcer, the range, and this was $2010, anywhere from 20,000 up to 150,000. And it's costing our healthcare system a lot of money. So 11 to 26 billion. Again, that was actually 2014, I think, data. So a lot more that is costing now in 2023. But as you guys are also familiar with, it is a significant increase in the nursing staff workload. So 50% increase when those pressure ulcers are there. Next slide. And then here are the most common places. So basically the bony, the places where we don't have a lot of soft tissue coverage, that's where you're going to be seeing these pressure ulcers, as you guys are also familiar with. Next slide. So which of the following are factors in development of a pressure ulcer? Immobility and debility, infrequent offloading, malnutrition, D, urinary and or fecal incontinence, or E, all of the above.
We have an E in the chat as well.
Yeah, I was making sure I didn't have any unanswered chat questions here.
We're at 64 responses. And it's overwhelmingly E.
Perfect. So those are definitely the biggest factors in development. Although there is many more, you know, smoking, malnutrition there, other chronic conditions. There's many risk factors that contribute to pressure ulcers, which we'll talk about in a few subsequent slides. Next slide. So actually this slide. So this, they looked at pressure ulcer risk factors, and actually I found this very interesting. So actually the people that are paraplegic versus quadriplegic, that had a greater risk factor of being paraplegic versus quad. So, and I think, you know, when you think about the people that are paraplegic, you know, they are a little bit more mobile, they might be in wheelchair, so they're kind of sitting in those areas a lot more, and they tend, and maybe they're maybe they're more likely to also be like smoking or something like that that might contribute to their ulcer. So kind of interesting there. But of course, their malnutrition, so a twofold increase, or odds ratio 2. Diabetes, also a significant risk factor. Underweight, of course, because they don't have the protection there, so that they don't go on to develop that breakdown. And other risk factors such as being male, Black, having those other chronic conditions like chronic COPD, incontinence, and actually protective is obesity. Next slide. So here you can see kind of the classification from stage 1 through 4. So that 1 where it's intact, but it's not blanching after you've relieved that pressure, versus when we start to lose the tissue, just the top layer on the stage 2, versus 3, where we're really starting to see that fat or that muscle layer. And then 4, you've got like full thickness loss. You might see bone, you might see joints, or even or some tendons. Next slide. So stage 3 and 4 are these one where you're really getting down to the bone, the joints, the tendons, the muscle layers. Really, to clear those up, it's pretty much a surgical management to achieve wound closure. Next slide. And next, we'll talk about some of the kind of colonization versus infection. True or false? In a chronic wound, the only good bacteria are dead bacteria. Is that a true statement or false?
I'm going to go ahead and end it because that's about where we've gotten with the others.
False. So yes, and I will say that also is the last poll question. Next slide, Nadine. Perfect. Okay, so this is, I kind of like this graph. I adapted it. Again, I think I got bored with the graphics. So this is one of my bio-rendered graphics, but it was out of the International Wound Infection Institute, and they have some really interesting, I felt like helpful kind of graphs and information in there. But I think this is a kind of a good representation of moving from what we see so much of, which is bacteria in wounds, whether that be just a contamination, we might swab it, get some skin bacteria, or it might just be regular bacteria that are sitting there, some colonization. So that is no antibiotics indicated for those states. You might have low numbers. You might see stuff like more commonly, you might have things even like yeast or things that are not very virulent in there. Versus when you start to get increasing numbers of bacteria or organisms, I should say, or more virulent type of pathogens, it can start out just being kind of a local infection right there. Might get away with something like a topical antibiotic or just really wound care. But as it proliferates and as it grows, this is where we're getting into that spreading infection and then systemic infection on the far right. And really those two conditions on the right is where we really should be putting people on antibiotics. Next slide. Although the sides on the left, contamination and colonization, is where a lot of antibiotics are happening. And then this is just, again, kind of an extension of that, just talking about the different kinds of signs that you would see with those situations. Next slide. As I mentioned, so the far right, the spreading infection, systemic, where you're starting to have fevers or you're spreading redness around it. You might start to have lymph node involvement where you can kind of see that redness spreading along the lymph node tracts. Those are definitely indications for antibiotics. But when you're so many of these cultures are just they're just regular things that are sitting in the wound, things like negative staph, or we get things like E. coli that really wouldn't cause like a skin infection. They're just in the wounds. They don't need antibiotics if they're not having signs of infection. Yet those conditions are really where about 2/3 of our antibiotics are going. Next slide. So these are moving on to kind of some of the initiatives. This is kind of the main ones that we'll focus on for the rest of the session. So culturing stewardship, improving our practices for obtaining cultures, the facility guidelines, decision support, some things like bundling. And then lastly, we'll do some communication strategies. And then I have some more resources for education. But just keep in mind, there really are a lot of things that we can do to improve our antibiotic use. So this graphic, there's many things. So we could do things like we've talked before, other sessions about like formulary restrictions or requiring prior authorizations or pre-authorizations for things like, for example, like linezolid or, dalbavancin, stuff like that. We also can incorporate dose optimization, streaming and de-escalation into that. You can develop your own guidelines, which we'll go through. Other things like antibiotic timeouts. You could also focus on penicillin allergies, would be a really high yield thing to do to address skin and soft tissue interventions. Next slide. So this is a graph of basically what I think about for kind of the wound. So the top layer, you're probably, and this is what we'll get a lot of these swabs for. So we're going to swab it and we might pick up some bacteria, but is that really what's causing infection? It's, a lot of times that's not really what's going to be contributing to it. So the deeper you can get that culture, more like, a deep specimen, a punch biopsy or something like that is going to be a lot more accurate if you're really suspecting that this has infection. Because as we know, the surface wound cultures results do not frequently equate to what the true infectious culprit is. So just getting a swab off the top of a wound surface has a sensitivity. I forgot to put the citation here, but I think this was from a meta-analysis, around 49%, so very poor. And the specificity also not good at 60%. But when you do get the cultures, we can make sure that we're getting the best cultures possible. So again, this was out of that International Wound Consortium, kind of when they go into culturing stewardship efforts. But when the swab is used, basically trying to press as hard as you can to really release some of that gunk out of there. Rotate the swab over like a centimeter square area. Getting that fluid and trying to get the deeper stuff upwards. And that really is what you're going to hopefully intend to culture. Next slide. So this is a graph from kind of the best to not the worst, but the maybe lowest yield. So really you're working on specimens. So if you can send specimens pus, that is really going to be the most helpful in identifying your culprit. Versus you get into the swab. So there's a picture of the traditional swab versus the flocked, and you can see the flocked where it has a lot of those little bristles. So it's going to capture a lot more bacteria in that. And then on the far right, we'll have what we most frequently will use is either the blue one, the gel swabs, which can be either aerobic, anaerobic, or fungal cultures. And then the one on the far right, the sponge swabs, also similarly, you can get those are all the same, the aerobic, anaerobic, or fungal, but you can also use those for MRSA PCR test. Next slide. So, and before we even get the culture, we can think of like our pre-analytic state. So you could focus on making sure that people are only ordering swabs or cultures if they feel like there's a high pre-test probability, meaning there's infection there, there's redness, there's systemic signs of infection. So that's kind of number one. Next, before we get to the results, we can focus on optimizing the cultures, like we've talked about, getting those deep swabs, debriding the swab, and then getting that deep culture afterwards, especially in wound clinics where they'll be doing a lot of that, in order just to get that gunk off the top of it that is the contamination and not the true pathogen. And then kind of avoiding, just like avoiding blanket cultures for the same thing that we talked about with the UTI session, making sure that we're really focusing on getting cultures from something that we think is infection and not just blanket because someone had a confusion or a fall or something like that, and we swap their wound. And then we get into analytics. So this is going to be things like adjunct tests such as MRSA to determine colonization from infection, and culturing at really, again, similar to the pre-analytic only signs of infection. One thing also, you can pull in your lab colleagues, your reference lab, and work on getting some nudging or how they report those results back. And we'll go kind of through what some examples include with that. Next slide. So this was a intervention where they used, they incorporated clinical practice guidelines for skin infections, soft tissue infections, and I believe they included wounds and abscesses actually. So what they did, this facility, and this wasn't a long-term care, this is actually an inpatient setting, because I was kind of struggling to find actual one guidelines that they implemented it for long-term care. So that is an area of interest if anyone does think about doing any information like that. But anyway, what they did was they did an order set, and then they included an educational campaign. So they disseminated this guideline via email. They put it in work areas where there was nursing work areas, where the provider work areas were. They also put that up on the intranet that the providers had access to. What they found was that it reduced just putting this kind of order set and this information, this algorithm out there. It reduced culturing by 14% less cultures. So it went from 80 to 16% or 66%. And additionally, what it decreased is unnecessary imaging. So people weren't ordering CTs as much. So they, for people that presented with cellulitis, it reduced their CT and MRIs by 14%, versus those that look like abscesses, they actually more appropriately then did get the imaging there. Next slide. And then this was a separate, this was actually one for pressure ulcers in nursing home. And this too was where they incorporated those guidelines. They created like an education package. So this gave things like the policy for preventing and managing wounds. And then they incorporated with an electronic risk tool. And so this was the PURA tool, or it was the Silver Change Pressure Ulcer Risk Assessment. And basically that was based off the Braden scale. It was just like an electronic tool that they could incorporate. And so it wasn't like not a complex intervention that they did. But what they did is they found that this, and they didn't give any long-term outcomes. So they didn't actually give any outcomes on wound outcomes. But what they did look at was the nursing perceptions. And so there was pretty much universal agreement that this tool actually helped them improve their assessment and strategies to prevent these and manage these people with wounds, and people to prevent wounds of people that are high risk. They agreed that by providing these tools and kind of this practice change, the bulk of people really agreed that the workflow and knowing those guidelines really helped them to incorporate that easier, where it was kind of a novel course to have these guidelines in this nursing home. Next slide. So antibiotic optimization opportunities, so this is with any infection, but certainly we could also focus on making sure that we're getting the right drug, the right route, the right doses, but also the right duration. So there's been at least four randomized controlled trials looking at skin infections where they found that 5 versus 10 days, there was no change in cure. And as we mentioned on the clinical, like the guideline examples, really focusing much more of these infections are strep than staph. So probably not needing as much of the MRSA coverage for those, but also eliminating a lot of the other things like, regular cellulitis. You're not going to be really at risk from like anaerobic infection or Pseudomonas. So we don't need those kind of coverage. And then we can also just focus on the route and the dose. Uncomplicated skin and soft tissue infections, pretty equal efficacy between IV and PO. but a lot less complications for the PO and decreased costs. So we should really be building our guidelines based on those. Next slide. So this was where they looked at incorporating the guidelines. And they specifically looked at reducing the antibiotic use, actually. And so they found, like, as we just talked about, very few infections are going to need like pseudomonal coverage. So they found that by incorporating these practice guidelines, they reduced the anti-pseudomonal coverage by 10%, but they cut down on the duration by 3 days. And really, they cut down on those super long courses. So the courses more than 10 days, they dropped those by a quarter. So really minimizing the antibiotics only to what was needed to cure that cellulitis or the skin infection. Next slide. And then again, another example of a intervention that was done. And this example from Ridgway and colleagues, they actually incorporated these guidelines. So they incorporated their guidelines that they developed into a clinical decision support system. And so it was providing these suggestions about antibiotic management and duration for non-purulent cellulitis. And so they actually allowed this decision support, pulled in the data into the EHR. It actually allowed to pull in like prior micro results, also the renal function to make sure they were getting kind of the right dose optimized. And what they found is this was an inpatient setting. So they found that it decreased the length of stay, actually 47%. So significant improvement with this one on the length of stay. But they looked at longer term outcomes too. They made sure that by cutting down these durations and minimizing these antibiotics, that it wasn't impacting morbidity and mortality. And indeed, at the 30-day mortality, there was no change with the intervention using these algorithm. And then also on readmission, so making sure people aren't getting readmitted with cellulitis that was partially treated, that didn't have any change either. Next slide. So here, this is a really complicated kind of algorithm from this example where they actually incorporated this, the guidelines. They incorporated some other adjuncts. So things like making sure that people that had elevation, or they had alternative things like NSAIDs for pain control. It did incorporate as part of the their guideline as their algorithm, the antibiotic choice and duration. And then this bundle that they did, so they put this bundle example, this example right here with this algorithm. They posted this in like common areas again, where the workers, the prescribers would be sitting. They put laminated copies in work areas. They put this out via the print and email and intranet. And then also this was a facility that had learners. So they provided education to resident and faculty also. And then they actually provided audit and feedback via Monday through Friday via text or phone. Next slide. And then, so this is another example of an algorithm that you could incorporate. So that one actually was a little bit more complicated on the prior side. It actually had examples of like, were they at risk of like bite, etc., little things that maybe not as frequent in our long-term setting. But this one really is more of an algorithm for when to get like culturing. And I pulled this off of the European Wound Management Association. I was looking through I was trying to find some really good examples of education material and algorithms, and I thought they had a lot of resources that were good. But if any of you are familiar of anything in the US or Canada that provides, like there are some, but these were just, I thought, so exceptional compared to what I found for the US kind of stuff. And there's the download too, if you do want to look there, kind of algorithm for culturing or not culturing. Next slide. So the prior study where that bundle was, they looked at doing that combo of things with the education, the algorithm, all of that stuff. It actually reduced the length of stay by 1.4 days. And then actually this one actually had an improvement on mortality and reduced 30-day readmission. But you can see by the p-values, both of those weren't statistically significant, but actually had a trend towards lowering those. They also looked at antibiotic use as their outcome. And so they found that there was a 29% decrease in total antibiotic duration. So like made a lot of headway in cutting down on those super long durations. And importantly, what they did do is they reduced the inappropriate broad or coverage, such as anaerobic or gram-negative coverage. So gram-negative, they reduced it by 56%, and anaerobic antibiotics by 47%. Next slide. So this is one of those things that I kind of mentioned before with the micro nudges. And so this is endorsed by IDSA and SHEA and CLSI. So this is basically, so it's a nudge. So you wanna, you provide some kind of information that either presents desirable options to the people that are looking at those results or the prescriber, or maybe you hide the like less desirable options. For example, you would hide that this that there was you know, something you know, some kind of thing in the result, and I'll give an example of kind of some phrases. Another option is you can frame recommendations with comments in the result. So you could put something like, there's no MRSA or there's no Pseudomonas in this, so unlikely that, you know, blah 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 would be needed. But another option too, another form of doing this is to provide like visually enhancing the desired option. So really kind of highlighting what is positive or negative, or hiding what's negative. Next slide. So this would be an example of a nudge, of a reporting nudge, a micro reporting nudge. And so, as I mentioned, putting something like the no MRSA or no Pseudomonas, so that providers then eliminate those antibiotics who don't feel pressure, they can de-escalate off of those. Another example would be to put something like, there's no neutrophils or pus cells identified in the sample, indicating minimal inflammation, possibly consistent with normal flora contamination. So another thing where, you know, we're not seeing the white blood cells, so this is not looking like there was something, a lot of inflammation going on, subsequently not probably infection. Another example of that would be this or you could even stop the specimen being processed. This specimen will not be processed further, as the microscopic exam shows epithelial cells with minimal inflammation. Culture may represent bacterial colonization. So as I just I skimmed over on the prior slide, but this is something where if you partner with your lab to make sure that you're kind of, you need to have the end users, you need to have the prescribers, the micro personnel to determine what kind of comment, what kind of nudges you really want to provide there, so that everyone is determining it's in the best interest for that result. Next slide. So moving on to communication strategies. So this is, I believe I showed this same study in the last session, the UTI one. And this was actually a study where they looked at communication strategies on antibiotics. So all comer antibiotics, not just for skin infections. But what they found is really there's several different things that affect our pressure to prescribe antibiotics. You know, our norms, the people around us, our other prescribers, you know, the antibiotic prescribing tendencies in that clinic or that pod or that place. So that is significant, but less significant, the biggest factor is actually this action bias. So rather than having the social norms or you know, neglecting information, the biggest pressure or the biggest factor in prescribing antibiotics is because we want to do something. So we don't want to tell someone, you know, like this inaction bias. So I don't want to like just tell them it's nothing and do nothing. So this, again, this was the biggest factor in prescribing antibiotics. So what we can do is we can look at that action bias and try and create some message, kind of frame it in a way that kind of then goes towards that bias of wanting to do something. Next slide. So this is an example of how you could reframe that to target that action bias. So this would be an example of like the prescriber. So I could be talking to someone and say, yeah, we'll wait and watch on the, or wait and watch, or we'll wait for the cultures, but we're not doing anything. We feel the need to do something. A different approach would be by giving them things to do, by saying, well, we're going to start by elevating our legs at least 2 times a day. We're not going to dangle the legs, and we're going to start wearing those compression stockings. So you gave them things to do. We're not inactive anymore. Another example of an inaction kind of statement would be, we got the cultures are negative, there's nothing more to do. Again, you can frame it, good news, although we probably did not need cultures since the wound was not changed recently, they confirmed it is only normal skin bacteria. Let me know if you develop these signs and symptoms. So let me know if you develop redness, spreading, warm, pain, increased drainage, fevers, etc. So you're giving the patient something to an action to let them know what to tell you if things are turning worse. Next slide. So this would be some kind of framing messages from the nurse side. So an example of an inaction is likely not an infection. We'll call back or we'll check later if symptoms change. So instead, you could frame it as the chronic drainage is because the wound's open, but unless you develop, this symptoms that are symptoms of infection, we don't need to do anything. But let me know if anything changed, and then we'll get you to like a wound clinic. Another positive kind of action statement might be that one on the bottom. You could document it because we might have pressure that we want to have accountability. So an example is you could document in the chart, given symptoms are inconsistent with wound infection, I am documenting that no McGear criteria are met. And that way there is kind of this sense of we did something, we've looked at this, but we've assessed it not to need antibiotics or not to be infection. Next slide. So moving on to education. So this was an example of a study where this group did case-based, so this was nursing home residents, and they looked at these case-based discussions circling around skin infection, predominantly in some wound management stuff. These sessions were 1 hour, they were case-based, and they did 5 sessions. So they were small grouped, case-based, they did some video conferencing ones. And what they looked at is the performance of the providers after they completed these sessions. And so on a 3-point Likert scale, where the 3 was the highest of likely to make changes, the people that performed these 5 sessions on skin, cellulitis, and wounds for nursing home, they rated it as almost a 3 as more likely to make changes. Next slide. So this is an example of that one that they published in the MedEd portal. And so these actually, they provided the case-based stuff. And I will say they didn't just do wounds. They actually did one for upper respiratory infections and UTIs too, I think. And so you can download the presentations that they did. And then on the right is an example of the cases that they would have in their case-based discussion. And then there's additionally like a facilitator script to kind of go over, what management would you do, or what are the most likely pathogens, et cetera. So there is, if you're interested in that, that was kind of a helpful tools that I thought. Next slide. And then this also is that European wound consortium, that one that I felt like had a really great website, a lot of good resources. This actually, they had a wound management antibiotic stewardship kind of series. And so it's 3-week course for 2 hours a week. You watch these tutorials, these right here is an example of one of them. And it's some free e-learning opportunities. And then you can also sign up they have like a lot of interesting webinars upcoming too, but most all of them are focusing around wounds. So some of the topics that they cover in this tutorial, this educational piece, is antibiotic stewardship in the wound management, but identifying wound infections, but also preventing them. And then they also do they have some case-based stuff and some change management strategies. And I will say, plus, they must be based in the UK, so they have this very nice accent, so it kind of makes the listening go a little easier too. Next slide. And then, so this I pulled out of one of these ones on the right was from that same EWMA, the European Consortium. I thought they had some really good educational pieces to provide back to patients on like compression therapy, how it helps reduce their swelling, but also, other things, supports the veins, decrease swelling, increases blood flow. And then here's also another educational piece for This was from legsmatter.org. And so this was something to provide, like, especially for people that have wounds, about the importance of, looking after your wound, hand hygiene, etc. Next slide. There's many infographics and e-learnings if you want to check out. I thought those are great, both great websites. So, and we could actually skip this one. I think this was yeah, that is it. Does anyone have any questions?
If you have questions, please feel free to unmute. We've got about 5 minutes, or you can type your question into the chat.
Hi, Kelly. This is Casey Beck from KDHE. And great presentation. Antibiotic stewardship's a lot like hand hygiene. I think we hear a lot of the same info over and over again, but you always manage to provide us with new and interesting information. So in healthcare, as you mentioned, we see a lot of chronic wounds. And a lot of times the patients are seen across a variety of settings like inpatient, PT, ER, etc. So in considering culture stewardship, what would the recommendation be on how often to culture a chronic wound, or what guidelines would you suggest in deciding if a wound should be recultured?
Yeah, I would say the only time that makes it really simple. I think the only time that you need to recommend or obtain cultures is if something's changing in that wound, meaning if you start to see like redness around it, if the person is starting to notice some changes, such as like they're reporting increased pain for no particular reason that's out of the blue, if there's new feelings of sweats or chills, or of course fevers. But really the only time to routinely culture it, something's changing. That's the only time. So I wouldn't like routinely culture any swab, any wound. And I know even like I've did a webinar or a session not too long ago, and even some of the wound clinics were telling me that they actually just even send cultures of like wound dressings. Like that's a common thing to send. So even doing that, those low hanging fruits of like, we shouldn't be culturing like our drainage or anything, because really unless something's changing, don't culture it. I'm just proud of myself for getting done on time, finally.
Well, as always, Kelly, you have provided us with wonderful information. And reminder to everyone, if you are wanting continuing education credit, please stay on till the end so that you get the link to the questionnaire. If no one else has any additional questions, we had up to 85 people on the webinar today. I think that's a success. So thank you very much, Kelly, and we look forward to seeing you all. I think I have language here. Oops, I lost it. Our next webinar will be on the 17th of August at 1:30, and the subject that day will be initiatives for upper and lower respiratory infections and immunizations. So thank you all for joining us in the second of the antibiotic stewardship series, and we'll see you next month. Thank you. I think I just need to end it and you guys will get your links.